Good afternoon. On behalf of Pelham Medical Center and Spartanburg Healthcare System, I welcome everyone and thank you for joining us today. I'm Lindsay Lewis, the Interim Manager of Community Outreach. Our speaker today is Joseph Mobley, a board-certified cardiologist. Dr. Mobley graduated from the University of Alabama School of Medicine and did his residency at the University of Tennessee and Virginia Commonwealth University. Dr. Mobley is also well versed in invasive cardiology, nuclear cardiology, and coronary CT angiography, just to name a few. If you have questions in the upcoming presentation, please type them in the Q&A box, and I will ask them to Dr. Mobley at the end of the presentation. And now it's time for our presentation, titled A Change of Heart. We are very pleased to have Dr. Mobley join us today for the presentation. Welcome, Dr. Mobley. I will now turn the presentation over to you.
Thank you, Lindsay. It's indeed an honor to be here. Unfortunately, with everyone online, but nonetheless, it is certainly a privilege to be here and discussing with the community some of the basics of coronary artery disease, how it applies to individuals through time. And so I wish we could all be in person, but this format will have to do. So we will get started with that. So my objectives today are to talk about coronary artery disease. What is it? How do we, what physically happens when we have coronary artery disease? What is my risk? This is very important for everyone to understand how they can formulate an idea of what the risk for coronary artery disease is, and then what the possible problems that can arise from that are. And then to talk about some of the ways that we look for underlying coronary disease, diagnose it, and then some treatment options. I'm not going to get into a lot of the acute treatment options. It's more lifestyle and risk factor modification that I plan on talking about today. Hopefully this will give everyone a background as to how to address their own personal health circumstances in conjunction with their physician. So those are our objectives today. So the question to start this is, well, what are we talking about? What is coronary artery disease? And coronary artery disease is essentially discussing atherosclerosis. And atherosclerosis is essentially the development of plaque in the heart arteries, although the plaque can develop in other arteries as well, including the arteries going to the brain and other organs. But specifically today, we're going to talk about the arteries going to the heart muscle. And so this plaque builds up over time and creates narrowing of blood flow. Now, this is an inflammatory process that begins very early in life, and it creates several problems, either acutely or chronically, with the heart itself. So, as the heart arteries narrow through time, they can, if they slowly block to generally over 70 or 80% blockage, create a lack of oxygen flow to the heart muscle itself. And this can create long-standing heart muscle damage, which can weaken the heart. It can cause electrical problems with the heart, can cause congestive heart failure, it can cause a lot of other problems. These plaques can also rupture acutely. So as many of you have unfortunately probably known individuals through your lives who have had a heart attack, most heart attacks are actually acute rupture of a plaque, generally perhaps not even more than 20 or 30% narrowing, so not enough narrowing to actually cause resting problems in blood flow. But if the plaque ruptures and forms a blood clot, it can acutely block blood flow to the heart muscle and cause an acute heart attack. So these are the problems that we deal with when this plaque starts to develop. It's both can be an acute problem as well as a chronic problem. Now this problem, atherosclerosis, as you can see here on this slide, is a lifelong process, and autopsy studies have been done in individuals as early as their late teens that show the very early stages of atherosclerosis development. And the process slowly builds through time. And again, the body looks at these plaques like a wound and will slowly cause immune fighting cells, white blood cells that fight disease, infection, things like that. They migrate into the wall of the blood vessel and lay down cholesterol mostly. And over long periods of time, this plaque slowly grows until it starts causing a problem, either again, becoming vulnerable to rupture and acute problems, or just simply growing to the point that it blocks up flow at baseline. This is an actual histologic slide, unfortunately, of an individual who passed away from a heart attack. And you can see on the far right side of you can see sort of the tan streak over here. This tan streak is the base of the plaque, and then you have a lot of this sort of pinkish, what I would call junk in the middle, which is a lot of cholesterol and other inflammatory cells in the heart of the plaque. And this plaque has actually ruptured. And this up here, you see where this cap is very thin on the plaque at about the 12 o'clock position. That is the site where the plaque ruptured and then formed. This dark purple is a blood clot. So this is the problem with an acute heart attack, and it can be acutely life-threatening. So we have strategies to treat this when they're occurring, but we certainly want to prevent this from developing to begin with. So again, this is a slide of CT. So there are special CTs that can look at the heart arteries and plaque. And what you see is you can see a continuum of people on the left with no significant plaque, and then you start to see plaque, and then on the far right you see about midway down there is a tight narrowing, and that's a fairly severe stenosis or blockage that we can pick out with CAD. So you sort of see the lifespan of the plaque in this CT imaging. Now, this on the left is a CT image of a plaque. This is the same plaque on the right on a heart cath, which again, a heart cath is an angiogram where we place a catheter into the heart arteries and inject dye. And you can see at the very top here, these two plaques coincide, CT and cath, and this patient had a very severe blockage in this artery at the top of the angiogram and required a stent, which is one of the treatments for this. So these are sort of the end results of these plaques. Now, why is this such a big problem? Well, coronary artery disease is the largest public health problem in the United States. This is a very old slide. I think this data came around the early 2000s, and you can see even then the annual death rate from coronary artery disease dwarfed even a combination of cancers that are very common, as well as HIV. So what you were looking at is, at that time, and these numbers have only increased, 700,000 deaths per year. I think the most recent data is now over 1 million deaths per year from underlying coronary artery disease. And if you think about that, we have had a horrible year with COVID-19, and we just crossed the 500,000 death mark here in the last week or so. We average over double that every year from underlying coronary disease on a normal year. So you can see the public health problem for this. And this is only going to get worse. This data, which recently came out, suggests that in just 15 years, that there will be more than 130 million adults, which will be pushing 50% of the total US population, that will have some form of cardiovascular disease. So when you think about almost 1/2 of all adults in the US having some cardiac issues, it is a daunting problem going forward. And so prevention is going to become paramount to us to try to prevent as much cardiovascular disease as we can. Now, a lot of this falls to the individual patient because, as we talked about, coronary disease starts early in life and oftentimes before people are even going to a physician on a regular basis. And so it's very important for individuals to understand what contributes to their own risk. So in that, we have tools that go back really almost to the end of World War II. There was a large cohort of patients outside Boston called the FRAMINGHAM study, and they looked at a whole population of patients for years and years, and they were able to create risk profiles for underlying coronary disease. Now, this has allowed them to create a risk calculator or a risk score, and you can either Google search a Framingham risk estimator or go to National Heart Lung Blood Institute, nhlbi.nih.gov, which is through the Institutes of Health, and you can find these estimators. Now, what these look at are several risk factors, some of which you can control, some of which you can't. Age, gender, and race is the first. Recent blood pressure, so your hypertension status, your blood pressure status, your cholesterol, which is generally broken down into your HDL and LDL cholesterol, and we'll talk about that, your diabetic status, whether or not you smoke, and what treatments from a medical perspective, medication perspective, you're currently on. And you can see here, this is an example, and you place all this information in, and it will give you a 10-year risk assessment. So the Framingham risk score will pop up a 10-year risk assessment. And what we feel is that people who are low risk are generally less than 5% 10-year risk on the Framingham score. As your risk goes up, your risk increases. And when you get into the 7.5 to 20% range, you become more intermediate risk. And if you're over 20%, then you're high risk. And so even young individuals, people in their 30s and 40s, they can sit down and calculate these risks, and it helps them sort of understand what they need to work on from a risk factor perspective model to lower their risk even further and try to give themselves the best chance of not having underlying heart problems down the road. Now, there are other risk factors that are not calculated in the Framingham score that are important. Family history really can't do anything about. Genetics are part of this story, and there are certainly families who have very high risk. And what I tell people in that situation is if your family has a significant number of people who have had early problems with heart disease, you probably need to start seeing physicians early in life to make sure that your risk factors are well controlled to do what you can to prevent this. But other things that become important are your lifestyle. People who are very sedentary, don't exercise, they're overweight. That is a big risk factor for developing coronary disease and atherosclerosis. Diet is also important. Obviously, diets high in saturated fats, high carbohydrate diets, things like that, obviously are more prone to creating high cholesterol, obesity, which then implies higher rates of underlying atherosclerosis. So these things, again, genetics you can't do much about, but you can certainly do things about these others, your lifestyle, exercise, and your diet. Now, what is your risk? So at this point, this slide is here to talk about people who do not have significant underlying symptoms of coronary disease, but have higher risk factors and want to have some further delineation or about what their risk is. We see this fairly frequently. So say you're 45 or 50 years old, you have a strong family history, you have some borderline cholesterol, you're concerned about, but you're pretty active and you don't have any heart symptoms, no chest pain or shortness of breath. So the question always comes up, is there a way that I can further define my risk? And in this regard, a calcium score is an excellent way to do this. This is a special type of low energy CT, so you don't get a lot of radiation, you don't get contrast, you don't even need an IV. These scans cost about $130 at most institutions. Most insurances do not cover them because they are not done specifically for a symptom, but they are done to help us understand your risk. And on the left, you can see, well, I'll start with on the right, you can see all of this dense white material. This is all calcium. So again, you remember I was talking about atherosclerosis and the body looking at it like a wound. So one of the last features that the body tries to do to heal this wound or this plaque is it lays down calcium. And so it almost tries to heal it like a bone. And this calcium lights up with this bright white on CT imaging. And we can look at that and actually measure it. And then you see on the left, there was no calcium. So a calcium score of 0 really suggests minimal or no atherosclerotic plaque. And it gives you a very low risk for future heart issues. Whereas on the right, you see a lot of calcium, a lot of plaque, and obviously the higher the plaque number, the more plaque you have, the higher your risk. So for people who are not having symptoms but have a lot of risk factors, I often recommend they consider paying for one of these scans. They're cheap and easy, and they give us a tremendous amount of information which we can use going forward about your risk and your treatment. Now, what about people with symptoms? What kind of symptoms does coronary disease create? And what I would say is for the vast majority of people who have mild to even moderate underlying coronary disease and blockages, they most of the time have minimal symptoms, if any. A lot of times it is completely asymptomatic. But when it becomes more severe, either acutely in the setting of a heart attack or more chronically with gradual narrowing of the heart arteries, people develop chest pain, which is generally exertional. They develop shortness of breath. They can develop exertional cold sweats and nausea, and they can start to develop electrical problems with their heart, palpitations, arrhythmias, things like that. They can pass out from some of these things. So all of these types of symptoms are concerning to us and generally tell us that we need to do some further testing. Now, when we need to do further testing to see if we can diagnose coronary disease, there are several things we can do. And normally in the office, the first things we do in situations when people have symptoms that are concerning is an electrocardiogram, which is a simple electrical tracing of the heart. This sometimes is diagnostic, sometimes is not. This is actually an EKG of an acute heart attack that we would expect to see something like this in the emergency room if somebody came in with acute severe chest pain. In the office, it's often much more subtle, but can give us some clues as to what may be going on. We generally go on with some further testing. If people are able to ambulate and walk, then oftentimes we can do an exercise stress test. This is simply putting stress on the heart by walking you on a treadmill. And as the heart rate goes up, the need for oxygen to the heart muscle increases. And if you have blockages, then we start to see EKG or imaging changes based on this. These are some of the imaging modalities we use. On the left is a nuclear stress test. Some of you may have had these. This is where you have an injection of a radioactive tracer that is taken up by the heart muscle, and we can compare resting and post-stress pictures and see if there is a hole that develops. You see on the left, the post, right above post, you see that that bottom wall of the heart there on the post does not look as well perfused with tracer as it does on the rest or the top images, and this would suggest a blockage to the bottom wall of the heart. We also often do these in the office with ultrasound, where we can actually look at the motion of the heart and get a clue about underlying blockages. CT is less of a functional, stress testing is more of a functional testing for underlying heart blockages. You're looking for evidence when you exercise of underlying blockages. CT is actually in more of an anatomic look. It's actually looking for the plaque itself. And these CT scans have become much more sophisticated and much better at picking this up. And we're using them more and more in a lot of various ways to look at the heart and look at heart pathology. So this is another way we can look at it. And obviously, we saw this slide earlier, I believe, heart catheterization on the left, which is an angiogram, which really looks at the inside lumen of the blood vessel in comparison with the CT image of the same plaque on the right. Heart catheterization is still the gold standard for looking for underlying blockages in atherosclerosis, but of course it is invasive. It comes with a small amount of risk, and I want to stress that. It's not a high risk procedure, but it is a small amount of risk. And so unless the symptoms are really, really suggestive of underlying coronary disease, we normally try to start with a non-invasive means of looking at this first. And here's just some other images of CTs and caths. So how can we treat this short of winding up in the cath lab or winding up in my office doing some of these testing to look for it? If we want to start early in life, if we want to, or even if we have some mild underlying plaque that we know of, how can we prevent this from getting worse? So this really gets into medical treatment options. And not all of this is medication related. A lot of this is common sense, frankly. Prevention of underlying coronary disease, either primarily, which means trying to prevent it from developing to begin with, or what we call secondarily, if you have underlying plaque, trying to prevent it from getting worse. You certainly don't want to smoke. That's one of the biggest things you can do. So quitting smoking is paramount with people with atherosclerosis. Regular exercise and watching your diet, and well-balanced diet is key. So those are the three things you can start with, and you can start with those very early in life, and that's what I tell even young people who are concerned about this. Aspirin therapy. There's been a lot of controversy about aspirin therapy. Frankly, I think it goes along, the need for aspirin therapy is related to your yearly risk. And this has been shown to clearly be beneficial in people with an annual risk over 1.5% per year. If you want a rough equivalent without calculating your risk, I normally tell men over 50 with 1 or 2 risk factors, or women over 60, again, with 1 or 2 risk factors, that they probably benefit from aspirin. I think if they have fewer risk factors, the benefit is a little less clear. Clearly, if they're under those ages and don't have much of in the way of risk factors, I think the actual harm may be greater than the risk. So we don't recommend that for otherwise healthy people at younger ages, because there is some bleeding risk from taking aspirin. Cholesterol. Cholesterol control is key. Now, cholesterol control goals, generally, if you look at this generally speaking, you want your HDL, which is your good cholesterol, to be as high as it can, and you want your LDL, which is your bad cholesterol, to be as low as you can. And this has been known for years. Now, the specifics of this tend to revolve around your other risk factors. So we have different goals for your cholesterol based on if you have, number one, known underlying coronary disease, and number two, if you have certain risk factors. So, for instance, diabetes is now, diabetes and peripheral vascular disease are now considered coronary disease risk equivalents. Now, what that means is that if you have diabetes, but you don't have a history of underlying known coronary disease, we treat you like you have underlying coronary disease irregardless. As soon as you're diagnosed with diabetes, you're essentially classified as having underlying atherosclerosis because the coincidence of the two is so high. And so we really become more aggressive with your risk factors at that point. If you have coronary disease or a risk equivalent, your goal LDL, which is your bad cholesterol, should be at least under 100, if not under 70. So these goals continue to be ratcheted back and lower. You want your HDL, if possible, at least over 40 or 45, closer to 60 is better. So the higher, the better. So these are cholesterol goals. Now, what can we do? Obviously, diet and exercise is the mainstay, and certainly early in life and before you have a diagnosis of underlying coronary disease, we encourage people to try to use these lifestyle modifications to lower their cholesterol. If it won't come down, or if you have underlying coronary disease or risk equivalents, we also often move to lipid-lowering therapy, and the mainstay of this is statin therapy, which many people are on. Medicines like atorvastatin or Lipitor, or rosuvastatin or Crestor, or pravastatin. So all these statin medications have been around for a long time, and we're using them effectively. They number one, lower LDL. They also have some other factors that are beneficial. They can actually stabilize some of the inflammation of the plaques and make them less likely to rupture. So they're important therapies for people with underlying coronary disease. Triglyceride lowering is important. There is a different class of medications that we use as a second line to lower triglycerides if need be. And then there are newer therapies, the PCSK9 inhibitors. The two medicines there are Repatha and Praluent. These are injectable medicines that we generally use in people who are intolerant of statins. As many of you know, statins can cause some aches and pains. So if people have recurrent aches and pains on multiple statins and they can't use them because of those side effects, we will use some of these other medications. Therapeutic, again, other things to lower your cholesterol, like we were talking about, diet. People often ask me what types of diets to use. Good balanced diet is best. The TLC diet is one where you reduce your cholesterol intake. You try to limit your saturated fat intake. But there are others. I normally tell people a Mediterranean diet is not a bad diet to use. You want to use something that be on a diet that is high in fresh fruits and vegetables, low in saturated fats, fatty meats, things like that. Use minimal amounts of oil, avoid fried fatty foods, but the main thing is you want a diet that you can stick to. A lot of diet plans that are very difficult to stay on, I see patients struggle with because they're on and off and it's hard to stick with them. Obviously, you want to increase your physical activity and lose weight. We talked a little bit about the PCSK9 inhibitors earlier, so I will skip through this slide. You want to keep control of your diabetes, and I can't stress this enough. If you are diabetic, your long-term diabetes control is remarkably correlated to your risk of problems from underlying coronary disease. So if you can keep your hemoglobin A1C, which is the 3-month control of diabetes measure, under 6%, you can see here your risk of having problems is well under 5%. Whereas if your A1C is approaching 10, you can pretty much guarantee yourself that you're going to have problems with this. So this is just shows that you really want to be aggressive with your doctor in finding a regimen that can control your diabetes. You want to control your blood pressure. And normally we say, for the most part, lower is better, unless we're causing problems with people having symptomatic low blood pressure, like feeling like they're going to pass out. So we treat blood pressure pretty aggressively in people who have underlying known coronary disease. And I tell people, even if you don't have known coronary disease, you want to be fairly aggressive with your blood pressure control. Certainly, I would tell people you do not want normal blood pressure readings above 140/90. And the goal should be approaching 130/80 or below. And obviously, there are a lot of blood pressure medicines that can be used to help if needed. Here we go. So certainly, patients with diabetes and chronic kidney disease would get even more aggressive with their blood pressure. But again, the lower the better. So in summary, coronary disease is a leading cause of death in the U.S. It is a huge public health problem and is likely only to get worse through time. CAD has numerous risk factors and risk equivalents which need to be taken into account by individuals and by their physicians starting early in life, really, to create a plan to lower your long-term risk. There are a lot of diagnostic tests that we can use to evaluate for underlying coronary disease, both in patients who have higher risk factors and are not having symptoms, but also clearly in patients who do have symptoms. And there are a lot of medications that we can use to help modify those risk factors to lower ongoing risk. And this includes patients both in the setting of not having known underlying coronary disease, but risk factors, but also certainly patients who have underlying coronary disease. So, Lindsay, with that, I will turn it over to you.
Okay, thank you so much for that wonderful presentation. It was very informative, and I know I learned a lot, so I hope all of you did it just as much. The first question we do have today is, what is the difference between HDL and LDL cholesterol?
So they are essentially different lipid particles. They have different densities. That's the technical. It appears that HDL is primarily the mechanism to take cholesterol back to the liver to be processed and dealt with by the body, whereas LDL is more of a driver of depositing cholesterol into plaque and arteries. So that's why when the LDL is high and the HDL is low, you tend to skew towards plaque formation and atherosclerosis formation. That's why you want to flip those numbers, have a higher density of HDL than LDL, because that seems to minimize atherosclerosis progression.
Okay, great, thank you. The next question we have is, I know you talked a lot about diet. Can you explain what a Mediterranean diet entails?
It's sort of the same. There are a lot of cookbooks and things like that. Again, it's a lot of fresh fruits and vegetables, nuts. If you're going to use oil, it's light olive oil. It is fresh. It is lean protein, meaning fish, seafood, poultry, chicken, avoiding a lot of fatty beef, things like that. Fairly balanced diet. It's just one. It is, and most of the food is fairly tasty, for lack of a better term, and so it's a little easier for people to stay on diets like that. And there are lots of cookbooks. The mainstay of it is fresh fruits and vegetables, limiting your fatty meat intake.
Okay, thank you. Another question is regarding exercise, which we know is a big thing with reducing. What types of exercises do you recommend to reduce your chance of CAD, and how often should I exercise?
So recommendations are to exercise roughly 30 to 45 minutes, roughly 4 times a week, 5 times a week. Now, obviously, the stages of life, somewhat adjust what is possible. We normally try to get people to get their heart rate during exercise to approximately 80 to 85% of their age predicted maximum. How you calculate that, you take 220, subtract your age. So if you're 80 years old, that comes up to 140, and then you take 80% of that. So just running the math in my head, that's about 110. You want to get your heart rate to about 110. Try to keep it there for about 30 minutes. To simplify that, because most people are not going to do all that, I tell people a nice brisk walk at a reasonable pace for 30 to 45 minutes 4 times a week is probably reasonable. It's certainly above the age of 65 or 70. Most people can't do heavy workouts. Younger people certainly can, and in that regard, jogging is fine if orthopedically you tolerate that. I'm one, I can't tolerate, from an orthopedic perspective, running anymore. And so stationary bike, bicycling, swimming, water aerobics, anything that gets you active is important. And that's why I tell most of my patients that staying physically and mentally active is very important as we age to, number one, keep a good frame of mind, but number two, to help limit progression of a lot of these problems like coronary disease.
Okay, thank you so much. Another question we have is, what are some specific foods to stay away from that do cause high cholesterol?
Certainly, it goes back mostly, certainly fried foods. I try not to pick on, but on certain restaurants, things like that. But, hamburgers, hot dogs, processed foods, fried foods, anything like that is going to be very high in saturated fat, which is going to cause adverse problems on your cholesterol numbers. So again, you just want to avoid a lot of those processed, fried, greasy meals. Everyone loves a hamburger from time to time, including myself. It's all in moderation. You have to limit those types of things going forward long term. Enjoy them occasionally, but make it a rare occasion.
Okay, thank you so much. The last question we have today is, I know there's a link between smoking and heart disease, but what about the Juul or other smoking alternatives?
I don't think we have all the answers to that. Certainly the biggest thing in cigarettes that has been linked to atherosclerosis development is the tar, but I say, and the nicotine. However, there are pro-inflammatory things and a lot of these, so a lot of things that you inhale create an inflammatory response, even non-cigarette inhalation. And so when you think about this, if it is creating a body inflammatory response, there is the possibility that it can be creating enough of an inflammatory response in the blood vessels to create atherosclerosis. So I generally try to get people to just try to get off as much as you can of these other things.
Okay, thank you so much. I really just wanted to thank you again, Dr. Mobley, for that wonderful presentation. It was super informative and really helpful. I wanted to remind everybody of our upcoming virtual presentations. We'll be having a golf-focused presentation on Tuesday, March 30th by our certified Titleist Performance Golf Specialist, as well as a class focused on kidney stones on April 14th by Dr. Pryor. Both classes will be at noon, and you can register at spartanburgregional.com/events. Thank you again for attending, and everyone have a wonderful day.